treatment of very low risk and low risk prostate cancer. Now that we've described the potential treatments, let's see how they are applied to the actual treatment of prostate cancer. To understand this, we have to understand risk categories and what they mean. How prostate cancer is treated is guided by risk categories. Risk actually refers to risk of recurrence. Risk of recurrence refers to what the chance is that the cancer will recur or come back after treatment. Men are offered treatment guided by their risk of recurrence. Risk categories have been developed by monitoring thousands of men after treatment over many years. They are based on initial PSA, cancer stage, PSA density, and Gleason score prior to treatment. PSA density is equal to your PSA divided by the prostate volume on ultrasound. The risk categories have been summarized and treatment guidelines have been summarized by a panel of experts and published through the National Comprehensive Cancer Network, or NCCN. They are updated regularly, usually yearly. The general categories of risk are very low, low, intermediate, and high risk. Just to remind us very quickly, cancer staging is done to determine how advanced the cancer is and to predict the disease course or prognosis, or in other words, the risk of recurrence. It is based on the TNM system as well as the Gleason scoring system that we have discussed previously. So let's start with clinically localized, very low-risk prostate cancer. Very low-risk prostate cancer is defined as T1C, or a cancer that is found because a PSA is elevated, nothing is palpable, a Gleason score of 6, a PSA in the blood of less than 10, and a PSA density of less than 0.15. It's also low volume. Less than 3 out of the 12 biopsy cores should be positive, with less than 50% of each of those cores positive. In other words, this is a low-volume, low-grade prostate cancer. This is a very common diagnosis, and the NCCN has developed guidelines based on how long a man will live who has this diagnosis. If a man's life expectancy is less than 10 years, observation is recommended because it is unlikely this cancer will hurt him. Observation means monitoring the course of the disease with the expectation that palliative therapy will be administered if needed. It rarely is. If the life expectancy of the man is 10 to 20 years, active surveillance is recommended. This is done by doing a PSA approximately every 6 months, a digital rectal exam approximately every 12 months, and a repeat biopsy approximately every 12 to 24 months. Active surveillance has been found to be safe and avoids the side effects associated with treatment with surgery or radiation. While on active surveillance, approximately 30% of men will be found to have higher grade prostate cancer at repeat biopsy and exit to definitive local treatment. This is thought to occur because the higher grade cancer was missed on the earlier biopsies, not because the cancer evolved to be more aggressive while the man was being monitored. If a man's life expectancy is greater than 20 years, he is given the choice of active surveillance, radical prostatectomy, external beam radiotherapy, or brachytherapy. The choice of therapy is up to the patient. All are considered equally curative or effective. Let's move up one category to now low-risk prostate cancer. Low-risk prostate cancer is T1 to T2A, Gleason score 6, PSA less than 10. It is different from very low-risk prostate cancer because we've lost the categories of PSA density and volume. T2A prostate cancer specifically refers to a cancer that is 1/2 or less of only one side of the prostate. It is a small palpable lesion. If life expectancy is less than 10 years, observation is recommended. If life expectancy is greater than 10 years, the patient has the 4 choices of active surveillance: radical prostatectomy, EBRT, or brachytherapy. In some cases, a urologist would also choose to do a pelvic lymph node dissection with the radical prostatectomy to look at the lymph nodes. In low-risk prostate cancer, the PLND is often skipped because the risk of having a positive lymph node is so low. Of note, we have been talking about clinically localized cancer, very low risk and low risk. What happens if there's a surprise at the time of surgery and unexpected adverse pathologic features are found? Adverse pathologic features, or APFs, include positive margins, seminal vesicle invasions, extracapsular extension, or if a patient ends up with a detectable PSA post-surgery. In general, if a patient has a detectable PSA after surgery, he is offered adjuvant external beam radiation therapy almost immediately. If a patient has an adverse pathologic feature, he can be offered adjuvant external beam radiation therapy or careful monitoring of PSA, and then salvage external beam radiation therapy at the time of biochemical reoccurrence, meaning when the PSA starts to go up. A PSA should be 0 after radical prostatectomy.